Today, we're heading to New York. But before you start picturing, the neon of Times Square or the subway at rush hour,
Hmm.
I want you to erase that image completely.
Right. We are not looking at the concrete jungle today. We're looking at the actual jungle, or at least the deep forests, the farmlands. We're looking at rural New York.
Which is just a massive part of the state. I think people forget how big it is. We're talking about an area with about 2.1 million people. And on the surface, it looks idyllic.
Oh, absolutely. The postcards, the quiet main streets.
But beneath that, there's a quiet, sort of slow-motion crisis happening in healthcare.
Crisis might even be too soft a word. It feels more like a systemic collapse. When you peel back the scenery, the infrastructure that, keeps people alive is, well, it's crumbling.
And to really get it, we're cracking open a very specific, very dense document. It's the New York State Rural Health Transformation Program application.
It is a dense read. But it's fascinating because this isn't just some standard budget request. It's essentially a battle plan. It's New York State admitting the old way of doing things in these 47 counties is broken.
And they're putting a big price tag on fixing it.
A very big one. $200 million a year.
So, yeah, this is a blueprint for survival. And our mission today is to look past the bureaucratic language to see what is actually at stake. We're going to unpack the 4 specific initiatives New York is proposing to keep rural hospitals open and, quite literally, to keep rural citizens alive. Because when you look at the data in here, I was frankly shocked.
It is shocking, but if you work in public health, it's also tragically consistent with what we call systemic fragility. The whole system is brittle.
Brittle how?
One small crack, a bad flu season, a cyber attack, a slight dip in funding, and the whole thing can just shatter.
So before we get to the how, the 4 initiatives, we have to understand the what. What is the diagnosis here? Who exactly are we talking about?
We're talking about a population that is generally older, sicker, and poorer than the rest of the state. The median income is around $67,000, which is significantly lower than the urban centers.
Okay.
But the key factor for the hospitals isn't just income. It's the payer mix.
That term comes up constantly in the report, payer mix. Break that down for us.
It's critical. In these rural areas, you have a very high reliance on government payers, Medicare and Medicaid. And those government reimbursement rates are, well, they're often lower than what private insurance pays.
Sometimes they don't even cover the full cost of the care.
Exactly. So if your hospital's patient base is, say, 70 or 80% Medicare and Medicaid, you are effectively losing money on the vast majority of people walking through the door.
Regardless of how good the medical care is.
Right. The math just doesn't work. The margins are squeezed from the very start.
Squeezed is putting it lightly. The report says 9 rural hospitals have had negative operating margins for the past 3 consecutive years.
3 years. They are running on fumes, dipping into reserves just to keep the lights on.
And eventually those reserves run out.
That's the financial cliff. But the money is just the operational side. The human cost is where this document gets really heavy. The health outcomes.
I was reading that section and the suicide statistics just stopped me cold.
Yeah. That is one of the most alarming data points in the entire application. The suicide rate in rural New York has increased 83% since 2004.
83%. That's just staggering.
And it's now double the rate of urban areas. The report links this directly to social isolation, economic despair, and a severe lack of mental health providers.
So people are in crisis, and there is physically no one there to help them.
No one. And it's not just mental health. The maternity care deserts, that phrase is haunting.
It really is. What does that mean on the ground?
It means that nearly 48% of women in rural New York live more than 30 minutes away from a birthing hospital.
Imagine being in labor. Maybe it's January, the roads are icy. This is upstate New York, right?
Yeah.
And, help is a 45-minute drive away on some dark country road.
It creates immense stress, and the outcomes show it. Maternal depression is at 17% in these rural counties, more than double the non-rural rate.
And then there was this one statistic I circled. I called it the zero stat. It's about the pediatric workforce.
I know exactly which one you mean. It hits hard.
The pediatricians. It says in 16 of the most rural counties, 3 of them have no pediatricians.
Zero.
None.
If your kid has a chronic condition, say asthma or diabetes, you're traveling. There's no local specialist. You're driving, 2 hours to Syracuse or Albany?
So let's just recap. Hospitals running out of money, a mental health crisis, mothers without nearby care, and entire counties without doctors for kids. That's the diagnosis.
It is. It's a system on the brink of failure. a code blue for the infrastructure itself.
Which brings us to the treatment plan. This is the transformation program. And they're not just asking for money to plug holes. They're proposing 4 distinct initiatives. Let's start with Initiative 1. Rural Community Health Integration.
This is the foundational shift. Historically, you have to remember, rural hospitals operated on this sort of rugged individual model.
Right. Every small town had its own hospital, and it tried to do everything.
And that works until the MRI machine breaks and you can't afford to fix it because your patient volume is just too low.
So this initiative says that independent model is dead.
Dead. You cannot survive as an island. The goal now is integration. They want to create these networks anchored by what they call anchor institutions.
Which would be the larger hospitals, the more stable health systems.
Right, the big, stable players. The strategy is to bind the struggling rural providers to these stable anchors. It's about sharing the load, financial, administrative, clinical resources.
It's almost like a franchise model. You're a small outpost, but you have the backing of headquarters.
That's a good analogy. It allows for things like group purchasing, shared IT staff, but the most important part for the patient is this concept of no wrong door.
I love that phrase. What does that look like for a patient?
It means the burden of navigation is taken off of you. In the old system, you walk into a primary care clinic with a complex issue, they might just say, sorry, go find a cardiologist.
And you're in the parking lot Googling cardiologists.
And maybe you just give up. Under no wrong door, whether you walk into a clinic, call EMS, or end up in the ER, you're entering the same connected system. They navigate you to the right care. They make the appointment.
So you're not just kicked out with a referral slip and a good luck.
Right. And financially, this is huge. It helps stabilize those negative margins we talked about. It stops the bleeding.
Okay, so Initiative 1 is about building a safety net through teamwork. Initiative 2 seems to be about stopping people from falling into that net in the first place. It's called Strengthening Rural Communities. But it's really about primary care and artificial intelligence.
This is where we move upstream. We know the most expensive place to treat a patient is the emergency room.
Of course.
If you can manage chronic conditions at the primary care level, you save a fortune and you save lives.
They talk about the PCMH, Model Patient-Centered Medical Home. That's a philosophy, not a building, right?
Correct. It's an evidence-based model. It means your primary care doctor isn't just treating your sore throat today. They're the quarterback of your health.
But the problem is, these quarterbacks, these doctors, they're drowning in paperwork.
And that's where the tech comes in. This is, I'd say, the most futuristic part of the proposal. They are explicitly proposing the use of AI in rural doctors' offices.
Now, when we hear AI in healthcare, I think a lot of people get nervous. You know, they think a robot is going to make a diagnosis.
Right, or a chatbot will replace their GT. But that's not what this is. Not at all.
Okay.
No, quite the opposite. This isn't about replacing the doctor. It's about liberating the doctor from the drudgery. It's using AI for the heavy lifting of data. Things like chart note scanning, automated identification of care gaps, 247 triage support.
Okay. Automated identification of care gaps. What does that mean in practice?
Well, imagine a doctor has 2,000 patients. A human can't manually check every file to see who missed a mammogram or whose blood sugar is trending up. The AI can scan the whole population overnight and give the doctor a list. These 10 people need a call today.
Wow. That's powerful. It turns data into action.
And the documentation part, that's the biggest burnout driver in medicine. It's called pajama time, doctors doing paperwork at night.
Because they can't do it during the day if they want to actually look at the patient instead of a screen.
Exactly. If AI can listen to the visit and transcribe the medical notes automatically, it frees up the physician to actually look you in the eye. That's like creating more doctors out of thin air.
So it's like giving every country doctor a super efficient digital assistant.
That's a great way to put it. And it's coupled with physical upgrades, too, making sure clinics are ADA compliant. It sounds basic, but you can't have a medical home if you literally can't get through the front door.
A very fair point. So we have the network, we have high-tech primary care. But none of that matters if you don't have the actual human beings to staff it.
This is the bottleneck. An empty building doesn't help anyone.
Which brings us to Initiative 3, Rural Roots.
And this is, in my opinion, the hardest nut to crack. The workforce pipeline. You can't just post a job and expect a flood of resumes. You have to grow your own.
Homegrown talent. They're talking about starting early,
Yep.
like middle school early.
Grades 6 through 12. Getting in there and introducing kids to health careers before they even graduate. And not just, Be a doctor. They're talking about addiction medicine, behavioral health, EMS, the specific needs of their own communities.
So you're showing a 14-year-old, hey, you can make a good living helping your neighbors with the problems you see every day.
Exactly. It builds a sense of purpose and retention. But they're also innovating for the people who are already working. Look at the EMS strategy.
Ah, the regional remote learning hubs.
Yeah, this addresses a huge rural problem. EMS folks are often volunteers or work multiple jobs. They cannot drive 3 hours to a city for a training class.
They have lives, other jobs, families.
So the state wants to set up these synchronous, two-way video learning hubs. A paramedic can go to a local center, connect with a top-tier instructor in the city, and get trained without leaving their community.
That just makes so much sense. But there's a financial component to rural routes that I found absolutely fascinating. The recruitment to service pipeline.
Yes. This is the economic engine of the plan. This is what makes it sustainable.
Walk us through this because it's different from the usual we'll pay off your loans scheme.
It starts that way. A medical student gets funding. They commit to 5 years of service in a rural area. That's standard.
Right, loan forgiveness.
But here is the kicker. The practice that hires them, the rural clinic, has to contribute 5 to 10% of that doctor's generated revenue back into a fund.
Wait, so a slice of the money the doctor brings in goes into a pot.
Correct. And that pot of money pays for the next student.
That is brilliant.
It creates a self-sustaining loop. The doctor working today is literally funding the doctor who will join them in 5 years.
It turns the workforce into a renewable resource.
It does. It forces the system to invest in its own future rather than just begging the state for money every year.
Okay, we've got the network, the tech, the workforce pipeline. The final pillar, Initiative 4, feels like the invisible infrastructure. Tech innovation and cybersecurity.
It's invisible until it breaks, then it's a catastrophe.
True. But before the hackers, let's talk about the school telehealth proposal. This jumped out at me immediately.
It's a game changer for rural families, putting telehealth access points directly inside rural schools.
So walk me through that. Your kid feels sick, goes to the nurse.
Right. The nurse connects virtually with a provider. The parent can join the video call from their desk at work. They diagnose, maybe call in a prescription. The kid might even stay in school.
And the parent doesn't have to lose hourly wages, drive an hour round trip to the school, then another hour to the doctor.
Exactly. In rural economies where transportation is a huge barrier, that saved trip is a massive efficiency gain for the whole community.
They're also pitching e-consults for the doctors.
This is provider to provider. Say a primary care doc has a patient with a complex issue. Instead of sending the patient 3 hours away for a specialist appointment 6 months from now,
Which might not even happen.
right, they can do an e-consult digitally. The specialist reviews the case and gives the local doctor a treatment plan in hours, not months. It empowers that local doc.
It seems like so much of this plan is just about collapsing distance.
That's the core theme. Technology collapses the physical distance that defines rural life.
But with all that connection comes risk. Which brings us to cybersecurity.
And this is critical. Rural hospitals are prime targets for cyber attacks.
Why is that? Because their tech is older?
Precisely. They're often running, ancient software. They don't have the budget for dedicated cybersecurity teams. They're setting ducks for ransomware.
And if a city hospital gets hit, you divert ambulances 10 blocks away.
But if a rural hospital's systems go down, the next hospital might be an hour away.
That's a life or death delay.
It is. So the state is proposing a whole-of-state upgrade. Funding for risk assessments, modern endpoint protection, bringing these small hospitals up to the same security standard as the big city networks.
So let's zoom out. We've got these 4 huge pillars: integration, tech-enhanced primary care, the rural roots workforce, and the cybersecurity layer. What does it all mean?
It means New York is trying to move from a defensive posture to an offensive one. For years, rural health has just been about patching leaks. This plan is about rebuilding the hull of the ship.
It's a recognition that you can't just treat a rural hospital like a smaller version of an urban one. It's not Mount Sinai Mini.
It's a completely different ecosystem. It requires different funding models, different technology, a different approach to workforce. It's about equity. Your zip code shouldn't determine your lifespan. But right now, in New York, it often does.
It's a heavy realization, but it feels comprehensive, hopeful even.
It is. And it focuses on sustainability. That's the key.
I want to leave our listeners with a thought on that. We talked about the rural roots funding model, that idea where community funds its own future doctors. That circular economic model really stuck with me.
It's a fascinating concept.
It makes you wonder, if a rural community can fund its own future doctors through revenue sharing, could that model work elsewhere? Could it be the key to saving other dying industries in rural America? Could you do that for teachers, for farmers?
It raises an important question about community self-reliance. If you can build the engine locally, you don't need to rely as much on the state capital.
That's it for this deep dive into New York's rural health transformation. Thanks for listening. We'll catch you on the next one.